Hello all, I shall share with you an interesting case of post-coronary artery bypass surgery who presented with an acute coronary syndrome. We were able to successfully manage this particular patient with device synergy. We had to use multiple options to manage the calcified lesion. Well, this is a 70-year-old doctor who had undergone bypass surgery 20 years ago. He presented to a nearby hospital with recurrent chest discomfort. His troponin was positive. He was managed medically. However, he did not respond to medication, and so he was taken up for angiographic evaluation in that particular hospital. You could see in these images that here the circumflex artery is totally occluded and the left antedistal artery is also proximally totally occluded. However, you could see here that the right coronary artery is flowing well. It's diseased right from the proximal segment till distally, and it's heavily calcified, and you could also see that there is a very critical stenosis in the distal right coronary artery. The second image, you could see that the vein graft to the left antedistal artery is functioning well. However, beyond the anastomotic side, there appears to be a very critical stenosis in the left antedistal artery. They wanted to open up the right coronary artery. They went ahead, tried to balloon dilate it. It was uncrossable, so they moved on to a microcatheter to exchange it for a Rota floppy. However, the microcatheter wouldn't cross. So basically, they had a case of non-crossable lesion in the right coronary artery, and so this particular patient was referred to us with the possibility of doing a laser angioplasty to the right coronary artery, basically because it was an uncrossable lesion. In our hospital, this is how we planned. We decided that we would go ahead with the left antedistal artery first because we felt that it's going to be a much more simpler lesion. So we decided that because there was calcification, do Rota stenting through the graft with the help of intravascular imaging. The strategy for the right coronary artery was, since it was an uncrossable lesion, lacing to cross the lesion with the help of a 0.9 millimeter laser catheter. Then once we are across the lesion, go ahead with a microcatheter, exchange it for a rotafloppy, do rotablation, and then a balloon-based preparation and intravascular ultrasound guided stenting to that particular lesion. So we started the right coronary and the left antedistal artery through the femoral approach, semi-fresh guide catheter. That's a short Amplatz left catheter which provides good backup support. It's seated well inside the vein graft. In the second image, you could see that there are two areas of calcification in the vein graft. Proximally, it's the anastomotic site, and distally, as indicated by the green arrow, it's a chunk of calcification. So we went ahead, wired the lesion with a Fielder FC wire, and then tried to negotiate a caravel catheter across. Here you could see that the caravel catheter is getting stuck at the proximal lesion in the proximal calcified lesion. That's exactly at the anastomotic site. So this particular area was where the caravel catheter got stuck. We switched over to a fine cross catheter. The fine cross catheter also got stuck over there. So we decided that we'll remove the Fielder FC wire and try direct wiring with the Rota floppy. So this is what was done. You could see here that the Rota floppy, instead of going into the distal left antedistal artery, it was turning back and going towards the proximal left antedistal artery. And when we reviewed the images, we made out that there was a shelf-like projection here at the anastomotic side. That was the reason why the wire was consistently going into the proximal left antedistal artery instead of distal left antedistal artery. Now we made some modification to the tip of the Rota floppy, and finally we were able to get across the lesion, position it distally, started off with a 1.5 millimeter Rota burr at 180,000 RPM. You would see here that at 180,000 RPM, the burr is getting stuck at the proximal calcified segment. We increase the speed to 200,000 RPM. Here you could see that it's crossed the proximal chunk of calcification, but it's getting stuck at the distal chunk of calcification. We increase the Rota speed to 220,000 RPM. However, we're not able to get across. Now, we made a couple of modifications at this point of time. We decided that we'll downsize the burr to 1.25 millimeter burr. We would also use a 7-French compatible guide extension catheter, the telescope catheter, so that we could enhance the backup support for while doing a rotablation. Now, getting the burr across that particular lesion and closer to the lesion was extremely difficult for us. We had to use activated burr advancement. With the help of dynamo, we were able to get the Rota burr near the chunk of calcification. We started rotablation at 200 200,000 RPM. We were not able to get across the lesion. Now we increase the speed to 220,000 RPM. You can see here in the second image, despite increasing the speed to 220,000 RPM, we were not able to get across the lesion. Then we switched over to a new burr at the end of 3 minutes of burr time, the 1.25 millimeter new burr with the help of a judicious push, and at 220,000 RPM. You could see here that the burr went across that particular lesion. Once we were across the lesion, you could see that the flow is TIMI 3. Then we went ahead with IVUS evaluation. There was multiple areas of napkin ring calcification. It was thinned off. It was polished by the help of Rota ablation, and there were a lot of reverberation seen. Then finally went ahead with stent implantation post dilatation, and then we were able to achieve a good flow inside the left antidistinct artery. We thought that this particular procedure would take not more than 45 minutes or so. However, once we finished, when we settled down with the LAD, it was more than 2 hours. So we wanted to stage the procedure, but then ultimately we were forced to continue with the right coronary artery intervention also in the same city. So again, the 7 French compatible short Amplatz left guide catheter, well seated inside the right coronary artery. You can see that the vessel is diseased in the proximal as well as distal segment. Distally, there was heavy amount of calcification. By this time, we have already crossed 2 hours, so we didn't want to try multiple options. We straight away decided that we'll go with lacing. So we used a 0.9 millimeter laser catheter, went ahead with 80/80, high frequency, high joules. We were not able to get across. We used a field guide extension catheter. You could see here in the mid-right coronary artery, the guide extension catheter is positioned. Then we tried to get across. We were not able to do that. Then we did contrast lacing. Finally, we were able to move the laser catheter a little bit forward. And once we were done with that, we removed the laser catheter, tried to get a micro catheter as distally as possible, then switched over to a Rota floppy, and then we started with an 1.25 millimeter burr at 180,000 RPM, not able to get across. Then we increased the speed to 200,000 RPM. That point of time, the 1.25 millimeter went across the lesion. Then we upsized to an 1.5 millimeter burr at 200,000 RPM. We were able to get across the lesion. Once we were done with that, we could achieve TIMI 3 flow inside the left hand in the right coronary artery. Did an IVUS evaluation. You can see that there are multiple areas of polishing, there are multiple areas of reverberation, making us feel that the Rota ablation had really helped us. Then we went ahead with a balloon dilatation. It was a 3 millimeter balloon dilatation. Subsequently, we went ahead with stent implantation, distally a long stent, proximally a long stent, overlapping stent, and we were able to achieve TIMI 3 inflow inside the right coronary artery. Now we wanted to post dilate with a 3.5 millimeter balloon. At this point of time, we understood that the non-compliant balloon at 26 atmosphere, it was not really cracking the lesion. We tried multiple options. We were not able to open up that particular lesion. We switched over to an OPN balloon. In the first image, you can see that with the help of the OPN balloon, we were able to open up the distal segment lesion. That's how it opened up. And then we wanted to move towards a more proximal right coronary artery where you could see a significant chunk of calcification. We tried ballooning it at very high pressures, even at 45 atmospheres. We are not able to open up that particular lesion. And you could see, however, at this point of time that the flow inside the right coronary artery is TIMI 3. Then we did an IVUS evaluation to see furthermore what exactly was happening there. We made out that there was a chunk of calcification there. It was almost 360-degree arc of calcification. That was the reason why we were not able to open it up with even an OPN balloon at 45 atmosphere. At this point of time, patient had a little bit of hypertension. We moved towards the groin, made sure that the bladder was not indented. There was no evidence of retroperitoneal hematoma. Came back and continued with the work. Now we took an IVL. We gave almost 80 pulses exactly at that particular point. However, you could see that the IVL balloon is not fully opened up even at the end of 80 pulses, and we were short of gadgets inside the cath lab. Whatever gadgets we had in the cath lab for managing calcification had been utilized, and so we thought that probably we should call it a day. The flow was good. There was TIMI 3 flow inside the right coronary artery. Even the circumflex artery was retrogradally getting filled. However, there was a little bit of under expansion in the mid-right coronary artery. We thought that probably we should accept that particular mild under expansion, and we settled with that. Well, my learning points were most of these post-CABG patients, they are extremely difficult patients. They tend to have significant fibrosis, they tend to have significant calcification, making life difficult for the interventional cardiologist to manage this particular lesion. Now, how did we manage this particular patient? We attempted managing this particular patient with multiple devices. Device synergy helped us in achieving reasonable results for this particular patient. The short Amplatz left catheter 7 French was useful for optimal backup in this particular two interventions. Rota with 1.5 millimeter bar in LAD could not cross the lesion even at 220,000 RPM. We had to downsize it to 1.25 millimeter bar and had to use a power backup with the help of a telescope guide extension catheter. We also did intravascular ultrasound evaluation for optimization of results. Right coronary, the uncrossable lesion was managed with laser catheter 0.9 millimeter with the help of contrast. Rota with 1.25 millimeter and step-up bar with 1.5 millimeter bar at 200,000 RPM cross the lesion. Then we went ahead with non-compliant balloon. We also attempted angiosculpt, which we were not able to track it into the lesion. The stent under expansion was managed with OPN balloon, intravascular lithotripsy. Still had to settle down with mild under expansion. However, we were extremely happy that we ended up the procedure safely with TIMI 3 flow inside the coronary artery and no complications for the patient, and the patient is doing well for the last 3 months. Thank you.